along with that one drug, you might be running 2 or 3 infusions in tandem. So that actually modifies the historical models, because when these models were developed, dexmedetomidine was not around. So if you are using both, then of course one has to bear that in mind and make suitable modifications in terms of what uh, setting you are running your particular TCI model on. Again, every surgeon cuts tissue differently. Every tissue has got more or less uh, nerve supply in different individuals. Different individuals' thalamus are differently connected to the same nerve coming up the spinothalamic tract, as we all know. So different patients need different things on the same machine. That's what I have learned over the years.
Sure. So we'll go ahead with today's webinar there. Good evening, esteemed faculty and dear colleagues. Myself, Dr. Yogita Patil, welcomes you to our webinar on precision of TCI, TIVA, and future of depth of anesthesia monitoring. As anesthesiologists, we strive for precision and safety in anesthesia for daily practice. Target control infusions and total intravenous anesthesia have revolutionized the way we deliver and the anesthesia care. It has improved outcomes and enhanced patient safety. Additionally, depth of anesthesia monitoring has become increasingly important in ensuring optimal anesthesia care and outcome from anesthesia. So tonight we will explore the latest advancement in TCI TIVA and depth of monitoring, featuring expert insight from Dr. Kalpana Shah and Dr. Dheeraj. The session will be moderated by Dr. Subramaniam Mahankali. So let's embark on this journey to precision anesthesia and discover how these techniques can elevate our practice. I invite President ISA Mumbai, Dr. Sona Dave, to introduce Dr. Mahankali. Over to ma'am.
Thank you, Dr. Yogita. I now invite Dr. Subramaniam Mahakali to moderate the session. He is the founder member and the honorary president of the Association of TCI TIVA Anesthesiologists of India. He is the past section editor and on editorial board of Journal of Anesthesiologists and Clinical Pharmacology. He is the editorial board member of Indian Journal of Clinical Anesthesiology. His special interests include TIVA, TCI, POCUS, obstetric anesthesia, solid organ transplant, and of course AI, which Yogita just mentioned. And he has multiple publications in 20 peer-reviewed journals. He has written chapters in textbook of pediatric anesthesia and Storting anesthesia, physiology and pharmacology. And at present, he's a senior consultant and lead anesthetist at the Aster RV Hospital, Bangalore. Welcome, Dr. Subramanian.
Thank you, madam. First of all, I want to offer my sincere thanks to the ISA Mumbai Metro branch and to each one of you. It's a pleasure to be here. The reason why I'm very excited is I have got two exciting colleagues who have been part of the group in which we started the society. But to highlight how TCI has grown, how TCI has become important is, I moved from AIMS Delhi to UK in 2002. When I went there, the first time when I went to one of the consultants, there were around 54 consultants in Royal Belfast Hospital. And there was one consultant there who was sitting, and he told me straight away on the first day that he has not been using inhalation anesthetic. He has been using TIVA for 2 years at that time. I'm talking about 2002. And that was the time when we had the first generation of TIVA pump. Now, we had heard about TIVA. We had also used some amount of TIVA for patients with coming for for the eye surgeries, etc. But first time I saw, I was very excited. But I thought those pumps had a lot of limitations, and we could not easily titrate, etc. That got me a little bit thinking. I didn't adopt it early. But as it goes on, by around 2006, 2007, the second generation of pumps started to appear. Now, what we have is all over the world, including India, including here, we have got third generation pumps. What it offers is the access to the latest models, which helps us give precise anesthesia. I'm really, very passionate about moving towards precision anesthesia, because if you look at all the specialties of medicine, I think in terms of what is required, anesthesia is moving far, far ahead in terms of precision anesthesia. Because here we no longer talking about a dose depending on the build, etc. We are trying to find a way where we can give precise medication, and not only give precise medication to assess the precise effect. Now, these are the two things: precision anesthesia, so that we know what is reaching the blood, what is the concentration in the brain. That's the fundamental core. And also, we're using advances in the digital technology, understanding is the effect appropriate or not. We also have learned we should not give deep anesthesia. We should not give light anesthesia. And to enlighten on these two topics, I invite two of my brilliant colleagues. First one is Dr. Kalpana Shah. She's an excellent colleague. She has been part of this TCI TIVA group. We have formed IOTA group. She's one of the founding members. She is practicing, as you all know, at Jeslok and British Candy. What also is very interesting is she's a passionate teacher. I'm sure you all seen her moderating the classes, etc. And even though I'm an RCB fan, want to watch the match, but her talk is more important for me because she makes it so exciting. I'm really excited to hear from Dr. Kalpana about what all everyone needs to know about TCI TIVA, and why TCI is being adopted in other specialties. Like, for example, chemotherapy, they are adopting it because target controlled infusion is a unique way of giving medicines. Following that, immediately after that, we talked about not only administering what it is there, looking at the effect. We don't want to be giving too much anesthesia or too light. And to understand the basics of why we need to monitor the brain, what we monitor when we give anesthesia, what all we can monitor, and Dr. Dheeraj Masapu is an excellent colleague. So he is one of the key figures in the neuroanesthesiology. So he's a popular figure in the YouTube. He's also there on multiple platforms like Marrow, where he teaches it, and also an active member of Neurosurgical Society, Neuroanesthesia Society. And I'm really glad that these two excellent people are there to take us through the session. And I leave the floor to them, and we'll come back and take the questions at the end. So I think we'll take the questions after both the talks. And Dr. Kalpana, the stage is all yours. Thank you.
Thank you, Dr. Subramaniam, for that very humbling introduction that you have given us. And I must thank Dr. Yogita and Dr. Sona Dave for giving us this opportunity to present our experiences and our knowledge about essentials of TIVA TCI. So as we move on to understanding the basic of TIVA TCI, I would like to go through my talks with certain objectives, and I would like to talk mainly about the pharmacokinetics and dynamics of propofol, make you understand the 3-compartment model on which the TCI pump runs. And we will look at certain models and the differences and how these models came up, mainly for propofol as an anesthetic agent. Now, we remain in gratitude to Dr. Glenn. He is the one who actually developed the propofol, and he paved the way for the Milky Way. So if you see that 2,6-diisopropofenol, which is $1 billion solvent, and if you were to take this and dump it in a beaker of water, and you can see how immiscible it is. And hence it took an indomitable spirit of Dr. Glenn, who was actually a veterinary medicine specialist. He put in lots of lipid emulsions, cresol, egg lecithin, and formulations. And that's how we have the propofol, which we are using today. And we must give a shout out to him for the same. Now, understanding the pharmacokinetics and dynamics, these are very crucial concepts in pharmacology because they play a very significant role in development and optimization of drugs. Now, pharmacokinetic studies will provide us the information how drugs are absorbed, distributed, metabolized, and excreted by the body. And this can be used to develop different dosing regimes and predict the drug behavior in a patient. Vis-a-vis pharmacodynamics, that is what the drug does to the body. So that provides us the information that how is the drug going to interact with the body by giving it therapeutic effect, and how we can exploit that so that we can get an optimized drug efficacy with minimum side effects. So overall, when you understand the PK and PD studies of any of the drug, it is very essential to see that you understand this so that we can improve the drug safety and the efficacy. And at the same time, we are providing maximum therapeutic benefits to our patients. We all know Propofol is very fast onset, short-acting intravenous anesthetic agent, which requires very accurate titration. So the induction and maintenance of anesthesia, that is bolus with a variable infusion rate, and it has a very narrow therapeutic index. So we need to really carefully administer it, because underdosing, you may have a patient who's moving, or you may have awakening or a possible recall. And overdosing can bring about, decrease in the SVR, hypotension, respiratory depression. And remember, propofol is not an analgesic. So we need to use some adjuvants along with it, like opioids or a regional anesthesia or some multimodal form of analgesia. Now, why do we want this? Now, you do remember when actually anesthesia is one of the few areas in medical practice where it is very important that you achieve a very steady state of blood and the effect site concentration. So that's where your clinicians are able to exert a very fine and a rapid control over the targets. Now, when a drug is administered at a very fixed rate, like suppose if you're trying to give propofol at a fixed rate, then your therapeutic range is going to take a long time to reach. And then if you continue that continuous infusion, then it's going to have its effect for a real longer time, because it takes a long time to equilibrate through all the tissues. And this will lead to excessive concentration of the drugs. Vis-a-vis, if you're going to give this drug, say intermittently, I'm talking about propofol, then what is happening? You're having many peaks and many troughs. So you are going to have a pharmacodynamic hit, and then again patient comes back. That's the whole time in the surgery you're having patient yo-yoing and never reaching the therapeutic range. So when we had vaporizers, how we had the Bull's target, we had a MAC. So something like a TCI is wanted, where you're hitting a target concentration which is intended for that patient, for that particular surgery, for his body weight and for his height and for his gender. So the TCI pump needs a pharmacokinetic and a pharmacodynamic model. Professor Louis Scheiner from University of San Francisco in the late 1970s, he had discovered this. It's like a hypothetical 3-compartment mammalian mathematical model which was brought about. And what did he teach us? He taught us the relationship between a plasma site and an effect site concentration, which is best explained by this 3-compartment model. Now, supposing you were to give propofol with TIVA, and the bolus is going to result in a very high plasma concentration, which is going to be represented by V1, which is the initial volume of distribution. The clearance, of course, is K10. And then these drugs are then distributed and redistributed to 2 smaller compartments, which you can see here. One is V2, which is muscle, which of course has got a good blood supply, so it is rapidly equilibrating. And V3, which is fat, which has less of blood supply, so it is very slowly equilibrating compartment, right? And the distribution is represented in between these compartments by K13, K31, K12, and K21, which are nothing but micro constant. Now, the pharmacokinetic model will tell us the time course of the plasma concentration of this patient. You must remember that plasma is not the site where you want your drug to be having its effect. Your drug has to have its effect in the brain, which is the effect site concentration. So the bolus propofol will take time for the effect to occur. And this time delay has to be incorporated in this pharmacokinetic model. Hence, Louis Scheiner also created a effect site concentration, which is the brain. And taking care of this, the delay between the plasma site and the effect site is represented by a micro constant called as KEO, which is the delay factor to get the onset of the clinical effects. Now, when we talk of propofol, remember propofol is lipid soluble. So it has a very high volume of distribution in V3. Now, the volume of distribution in a steady state is the sum of V1, V2, and V3. The drug is moving to and fro from the compartment is represented by this rate constant. The rate constant also shows the distribution from the plasma to the brain. Now remember, the sizes of each of this compartment, that is the intercompartment clearance, is going to depend upon the property of the drug. and then their tissue binding. Hence, if this model works for propofol, it is not going to be the same for other drugs. So, as an anesthesiologist embarking on your journey for TIVA TCI, it's very important and imperative that you have a good knowledge of distribution, redistribution, metabolism, clearances to be understood by all of you when you embark on this journey. The next is a concept which we must know is context sensitive half time, which is nothing but the time for the plasma concentration or the effect site concentration to decrease by 50% once you have stopped your infusion. Now, if you were to look at typical context sensitive half time of propofol in about for an infusion which is lasting for 2 hours, it is going to be around 30 minutes. But as you continue your infusion, the context sensitive half time goes on increasing. Sometimes the terminal half life can be around 1 to 3 days if you have given your infusion for a long period of time in the ICU setting. Now, vis-a-vis, if you see fentanyl, for a 2-hour surgery, the context sensitive half time is say around an hour or so. So it is going to remain in the circulation for some time. Compared to that, the new kid on the block, that is remifentanil, is a rare exception because it gets metabolized very rapidly with cholinesterases in the blood, of which we have ubiquitous supply. So here, remifentanil has the context-sensitive half-time of just less than 5 minutes. So hence, a combination of propofol with one of these soft drugs which have come into the market like remifentanil is something very good for a TIVA TCI when you have your patients coming up wide awake once the procedure is over. The next concept, which I would like to make it very clear, is about plasma targeting and effect site targeting. You all would recall the 3-compartment model which I showed you, and the plasma is the V1 and the effect site was the brain. So when you're going to target the plasma, what happens is you want the plasma concentration to reach the therapeutic level. So it will never overshoot the set target. So it's going to take time for a steady state of the plasma to reach that of the effect site. So there's going to be a slow onset and a slow offset. So what happens? Can you see the gray zone in the plasma TCI graph? That is the area where your patient is going to be awake, or patient may have some movement, because that's the time it's going to take for the patient to be under. So that is why there is a slow onset and slow offset when you're doing a plasma targeting. Vis-a-vis when you're using a effect site targeting, if you have set up your effect site targeting, your plasma concentration is going to overshoot the set effect site. Supposing I have set an effect site targeting, say at 3, the plasma will overshoot up to 9, right? So you may get a pharmacodynamic hit because of the drug, but because it overshoots very quickly, it will achieve the target concentration very fast. So it's going to have a quick onset and a quick offset. As you can see here, there is no gray zone of patient being aware or having any movement. Again, trying to explain you the same concept. As you can see here, the effect site concentration in this graph is lagging behind the plasma site concentration. But most of our TCI system decreases this delay by raising the plasma site concentration beyond the intended effect site concentration. So what happens? The plasma concentration, the plasma site is pressurized, and hence it goes and fills the effect site concentration, and hence we are achieving the effect site target very quickly. So most of your TCI models are now using this. A quick word about KEO, which is nothing but a rate constant, where you describes the time lag between concentration in the plasma and CE, that is the concentration in the effect site. So larger the KEO, shorter is the time lag, and the patient will go under faster. Now this has been exploited by some of the, like say for a MARSH model and a modified MARSH model, how they've exploited KEO so that the patient can go under faster. I will come to it a little later. So having had understood the 3 main concepts, that is 3-compartment model, context-sensitive half-time, plasma concentration and effect site concentration, we now have a TCI model, right, which is a computer-assisted drug infusion system, which is nothing but your syringe pump. And you aim to achieve the user target concentration, either the plasma or the effect site. And on the startup, you will select the drug, you will, and put the desired PKPD model, you will input the weight, height, and gender of the patient. The system will implement the required infusion rate to reach and maintain the target concentration. So we have to move away from weight per kg thinking to a target concentration. And the user, that is you at the back, can then decide whether you want to increase or decrease the target concentration depending upon the clinical condition that your patient is, the co-administered drugs that you are having, and what is the stage of your surgery. You can, get the target concentration up and down. So is it, so similarly, as you can see here, you have a pump with a varying rate, which you have given as an infusion to the patient. And you have done this with the help of the pharmacokinetic model, which has been fed into your syringe pump, which is your TCI pump. And depending upon your knowledge of pharmacology and physiology, at the same time, looking at the patient's characteristics of the depth of anesthesia monitor, of the vitals, you can vary the rate at the end, depending upon the patient's condition and how you want it to be done. So it's a computer control system, regulating the drug delivery, giving you the desired depth of anesthesia, and target concentrations are calculated by the TCI pump. You do not need to do this. In fact, Dr. Schaefer requested, most of these groups like Dr. Charles Minto, Schneider, and Michael Struess to kind of review the TCI technology. And he came up with this paper, which they found that it is like more than 30 years of research, a very mature technology. Estimated use of more than 20 million patients have received it with a risk of hardly, 0%, because they found that only 1 in 7 million had some pump-related issues. And hence, we had many of these pumps in the market with lots of different algorithms which have come up and which have been developed. In this course of talk, it's not going to be possible for me to talk about each and every algorithm, but let me restrict myself to Propofol, one of the most used drug, and the different models which are working on for Propofol are, Marsh, Schneider, Kataria, Petfuser, and Eleveld, and let us see what differentiates each of them. So when we come to Marsh model, this was one of the first model which was developed, has been in practice for more than 30 years. It was Gavin Kenny and his colleagues who had brought it up, adapted from HEP's 3-compartment model, and they did use a data set of more than 150 patients. But in this model, body weight was the only covariate. So there was no allometric scaling. Here, when you switch on your pump, put in that you are using the Marsh model, the only thing that it asks you is the weight of the patient. It does ask you the age because you cannot use it below 16 years of age, right? So the central compartment, that is the V1 compartment, that is the loading dose that we are giving to the patient, V1 is increases with the weight of the patient. And all the rate constant which I had mentioned to you about K12, K21, K10, K13, these all are fixed, because it has got nothing to do with the age of the patient, what is the muscle mass, what is the fat, whether the patient's clearance is there or not. Nothing is there. Creatinine clearance is good or not, whether the liver is functioning or not, kidney is functioning or not. It did not look into anything. So if I were to put this model in our 3-compartment model, it had a very fixed V1 compartment, which was 228 ml per kilo. Everything rest was fixed. Remember, V1 is a central volume of compartment, which was depending upon the weight. Micro constant has no covariates. So this has no effect site. And the KEO is coming actually from another study, which is a drawback of this Marsh model. And of course, as I told you, it is only weight dependent. So it is going to work very well if your patient is, young, fine patient. In a non-obese and a not too old patient, is going to work very well. Right? Because what happens is, remember one thing, in a very obese patient, it doesn't work because the V1 compartment doesn't proportionately increase in size as we get bigger. It doesn't happen like that. So in an obese patient is going to have a limitation in the induction dosages, right? And because the V1 increases with the weight of the patient, V1 is 228 ml per kilo. Can you imagine the amount of dose of propofol that you're giving into a patient, especially if your patient, falls in the other two group and is not a normal adult? And that's going to give you a real good pharmacodynamic hit. So that's why they always say that marsh is harsh when you're giving it. Now, coming to the, which I mentioned to you about KEO. So when the HEPS model did the marsh, they put the KEO as 0.26, which was just hypothetical number that they had taken. So some of the algorithms which were developed, so some of the users did exploit this KEO, and they made the KEO to around 1.2. So they made it really faster. And that was referred to as modified marsh model. Now, because we were not able to use this model in the, we were able to use it non-obese and adult patients, Schneider came up with, along with Charles Minto in 1998, with another model which was again developed with PKPD based on volunteer studies. And that used height, weight, age, gender. It used all these. At the same time, it also used something called as the lean body mass. So here, V1 and V3, that is a central compartment, and the fat, which is a slowly equilibrating compartment, V3, were remaining fixed. But V2, which is nothing but the muscle mass, of course, it is going to get influenced by the age, because as you age, the muscle mass is going to be smaller, you're going to shrink. So V1 here is fixed at 4.27, so is the V3, but V2 was getting variable with age. And based on various samples and this thing, Schneider came up with this. So here you have V1, which is fixed at 4.27. The V2 is going to change with your age. V3 again is fixed because it was around 2.893. So these covariates like weight, age, and sex and height was added in this model. And gender, of course, was a part of it. And they used something called as a James equation because it was dependent on the lean body mass, right? So the central compartment was remaining fixed, however big you are, 50 kilos or 150 kilos. So remember, the bolus given was very small. So again, this was a very gentle induction you would have with this. Of course, age plays a very important role. So as you get older, your muscle mass is going to decline, and so does the elimination. But there was a bit of a problem when you were using this model in obese patient. So what was happening here when we were using the lean body mass, they found out that the James equation is a quadratic function and does not work in obese patient, because what was happening is short and overweight patients, the James equations, the lean body mass started becoming negative, right? So say beyond a certain point, beyond a certain BMI, the lean body mass was not holding true. So it was limiting the maximum BMI at which you could use it. And if the lean body mass becomes negative, then what happens is your elimination becomes high. Because elimination is becoming high, you're calculating a very high dose, so a larger bolus is given. So here they found out that the James equation was limiting the BMI for 35 in females and 42 in males. So here there was another limiting factor where we could not use for a higher BMI group of patients. Now the two key TCI models which were used for pediatric anesthesia was PET-FUSER and Kataria models. Both are weight-based, but they both differ in their patient selection criteria and the pharmacokinetic assumption. The PET-FUSER model was derived from the MARSH model, and it was designed for patients from 1 to 16 years between 5 and 61 kilos. It was very safe for propofol administration in this pediatric age group of patients. The Kataria model was optimized for children from 3 to 16 years. And of course, the weight was 15 to 61 kilos. It was slightly more restrictive. It was better suited for older group of children. Now, what was the key limiting factor in pediatric? There was an absence of effect site targeting because there was no established KEO values for children. So this means we could only use weight-based and we could only use plasma site targeting in these patients, right? So because there was no KEO. So these were the two pediatric models which we had. Of course, we had a lot of challenges providing pediatric anesthesia, to make it really safe, especially for neonates and infants who have a very immature hepatic and renal system affecting the metabolism and clearance of propofol. So this would again necessitate you to give a very lower dose. And additionally, these children were very sensitive to the cardiovascular effects of of propofol, particularly hypotension, because they have a very smaller blood volume. So you required to have a very closer monitoring of hemodynamic parameters so that the patients would remain stable. So one of the key limitations of TCI in absence of validated effect site targeting was this. So immature drug metabolism, lack of effect site, and higher sensitivity to hypotension. So these factors also brought about a bit of limitations in pediatric group of patients. Well, they answered it by, the obesity problem was answered by giving us the Cotonese model, which of course worked in very well in obese patients, say 85 to 141 kilos adults, and as well as children, say from 5.2 to 11.4 kilos. And they did incorporate the slower KEO compared to that in the Schneider model so that you could discriminate the time of loss of consciousness. So this was the Cotonese model. So if I were to sum up, you had MARSH model, plasma site targeting, working very well for non-obese and non-elderly patients. So young, nice patients, elderly ASA grade 1, grade 2, you can use MARSH model who can withstand the pharmacodynamic hit of a weight-based giving a fixed amount to the propofol according to the weight of the patient. Of course, the MARSH did not have effect site TCI. Then came in the Schneider model. Again, that was very good, but for non-obese and elderly patient. Cotonese worked very well for an obese patient. I had the Pitfiosa model for plasma site targeting for children. But what I did not have any data for neonates, for small children, and for young adolescents. So there was again a group of patients for which I did not hear. Supposing I was a 16-year-old teenager was coming in for anesthesia, do I have to sit there and wonder, shall I use Petfuser, shall I use Schneider? Which model should I be using? Hence, Dr. Egan and Campbell highlighted that we need to increase the utility of TCI by giving us one model which would rule all of this. And hence, the developers got into action. We had Douglas Eleveld, Professor Michael Struis, and Laura Hannebot, who started working on this. And they collected data from all the previous studies, and they came up with a general purpose pharmacokinetic pharmacodynamic model. Now, they needed to describe the size of the patient, from a premature baby to an obese adult. We wanted a model which would work in a wide range. So here, it was neither the total body weight, nor the lean body mass, nor the ideal body weight was not going to be sufficient. So we needed to do something called as an allometric scaling according to the size of the patient. So we needed to understand the size of the patient really better. So we go back to our physiological review made by Professor Max Kliber way back in 1940 to understand the allometric scaling principle, which allows the scientists to understand the relationship between small organisms and large ones. Now, as you can see in the figure, you have a mouse who's really small. He does not live long, but he has a very higher heart rate. Vis-a-vis, you have an elephant, which is really huge and large, which lives longer and has a very lower heart rate. Now, because of this difference in the metabolic rate, the energy requirement was also differing, the caloric requirement. The mouse would require not more than 120 calories, and that of an elephant would be around 5,000 to 6,000 per day. Now, despite of their different size and the nutritional intake, metabolism, the body compartment was scaled to a figure of 0.75 by Dr. Kliber. Now, this, armed with all this information, our developers went back, and I'm not going to bore you with the mathematical equations. They collected the data, and they went back to the board, and they found a model in which they use the maturation index, they use the scaling for this model. They also used whether we are using any covariate drugs, whether some other drugs were used or not, because if some other drugs were used, your requirement of propofol would come down. Right? At the same time, they used al-salami fat-free mass in males and females. And with all this, they came up with, validated a new general purpose model, which was, for a different age group of patients. They stratified them for non-obese adults, for children, for elderly patients, for patients less than 3 years of age. These dosages were titrated by using depth of anesthesia monitor of BIS between 40 and 60. And they collected the plasma samples to determine the plasma propofol concentration, which the samples were collected at regular intervals at every 30 minutes to a maximum of 10 samples. And that's how this model was then developed with the data from more than 30 studies, more than 1,000 patients. You had patients from 680 grams to 160 kilos, as low as 27 to 52 weeks to 88 years, with different variables like concomitant drugs, age, height, and gender. And they found this, they took all this Eleveld model, took all the values with the BIS index, with plasma concentration of propofol, and they came up with this dosing graph, which tells you the amount of propofol you need to administer. To achieve an effect site concentration, you need to program and achieve the effect site concentration, which is 50% drop in the BIS value. So this graph is going to make it really easier. Let us see how we are going to use this graph. If you have a patient, say 50 years of age, and if you're going to do just a sedation, then you need to keep your effect site target concentration around 1 to 1.7. And here you have the same gentleman going in for anesthesia. For that particular weight, that particular height, you would kind of use between 2 and 3. This is around more than 2.5. So this kind of a graph helped anesthesiologists to understand what is the target concentration we need to achieve. As you can see here in the pump on the first is a Schneider model, which I have used. Here the patient is the same. It's the same height, weight, everything of the patient. But in a Schneider model, I'm giving a bolus of 5.9, but I'm giving a infusion, continuous infusion of around 67 ml per hour. The lower one is the Eleveld model, where of course my bolus is a little higher, but there is no overshoot or overpressure, and my concentration as a maintenance fluid is very less. It is just 53.8. So we now have the showstopper model, which rules them all. Again, repeating it, you can use it for neonates as well as for elderly patients with high BMI, both for anesthesia and sedation. 680 grams to 160 kilos, 27 to 52 weeks to 88 years, weight, age, height, the gender of the patient, and the concomitant drugs can be put in. So this kind of simplifies your decision making. Which model to use? No, just go ahead with the Eleveld model, one purpose model, which is now available for propofol as well as for remifentanil. It improves the patient safety and promotes the confidence in TIVA users. Now, I'm sure I have kind of confused you, and you're going to ask me, hey, which model should I be using? Well, use the model in which you are familiar with. Remember to see the 3 C's, the characteristic of the patient, the co-administered drugs, and the clinical situation. We recommend that you start with a lower concentration and titrate as you go up. Now, despite the differences between, Marsh and Schneider, you can achieve a stable plasma concentration as long as you're familiar with the model. You start off with a low concentration, and you keep in mind, if you're having an elderly, sick, obese patient, the risk of overdosage is always going to be there. And reduce the initial dose in compromised patients if they're coming in. And your mantra should be titrate, titrate, titrate as you go up. We believe that the Eleveld model will supersede both of these models and become the model of choice in all population. But remember, until then, titration is the key to safe delivery of propofol TCI. Now, let me discuss a few caveats. You titrate from, start from 0.5 to 1 mic, keep stepping it up, especially if you are going to do an airway manipulation. Are you giving a muscle relaxant or not giving it? Observe your effect site concentration, and depend upon the characteristic and the stage of the surgery, you can, increase or decrease the infusion as it may be. If you need a quicker induction, then of course, effect site targeting is much better. Make sure that, your dead space between the propofol infusion line and the IV axis, it's primed because before you're running the pump, and there is an IV running by the side of it. Begin the propofol infusion as early as possible. And some of your TCI pumps will, of course, allow you to give you a bolus as your initial target once you're setting it up. This can be adjusted if you want a quicker induction and if it is necessary for you and your particular case. Now, the maintenance of this is, as you titrate it up, see your depth of anesthesia monitoring. I'm not going to go into the depth of anesthesia because Dr. Dheeraj is going to take a real extensive class on the same. And decide how quickly your patient is falling asleep. So we will know you can personalize the target control infusion for that individual patient, and that would be the time when at the same concentration when the patient will also wake up. So you will know the wake up concentration, you will know how much of the drug has gone. But remember, when you're using propofol, you're just giving a hypnosis, so it's always better that you use some opioid for for analgesic effect. So putting it all together, propofol with a titrable opioid like say remifentanil is our choice and our practice. We use propofol for loss of consciousness and opioids for noxious stimulus. And you generally maintain the target concentration between 3 and 5 for propofol and around 2 to 4 nanogram per ml for your remifentanil infusion. Remifentanil as a co-induction also will have a mild effect and have a potassium sparing or a propofol sparing effect for loss of consciousness and return of consciousness. Now, what happens when you're using some different drugs? Which one do I stop first at the end of the surgery? So you titrate down the drug which has the slowest kinetic first. Now, the sequence will depend upon the drug that you are using and your personal preference. Supposing if I'm using propofol with remifentanil, propofol is slower than remifentanil. And if you're using fentanyl and propofol, then fentanyl's context sensitive half time is more, so it is again slower than propofol. And of course, if you have another adjuvants like ketamine or Dexam, which are being used, you can consider discontinuing them before the end of the procedure. And rather than powering your pump off, it is always better that you put your target site, that is your effect site target, to be 0. And this, again, as I mentioned, will allow you to calculate your decrement time, helps us to judge at what level the patient is becoming conscious. Here is a small video which I'm showing where I'm using remifentanil and propofol for my patient for a CABG surgery, where I have used LMA for as a airway device in this patient. So I use this basically and have started the patient with remifentanil and started with propofol as well, titrating it up and up down till my BIS level comes good. I'm not using any nitrous oxide or any inhalational agents. And after the patient is under and catheterization is started, I have manipulated the airway by putting a ProSeal LMA, which I like to use in our patients because I think it is more stable for throughout the procedure. I can reuse it again. My cuff pressures are very less over here, so the pressure effects are not there. After I have placed the LMA, I need a couple of checks to consider that it is in place, apart from seeing the expired tidal volumes and expired minute volumes and tidal CO2, auscultating the patient. And after the fixation, we do something called as a block test, where I put some jelly and on the DLT end and check for the jelly to be blocked. And once the rice tube is in place, I know that I've placed it very well because this is a coronary artery bypass grafting. I will not be able to manipulate it later. And here is my patient with remifentanil and propofol infusion without the use of any inhalational agents, which I have been doing since quite some time. And I've been very successful with the same. So friends, just to tell you that ultimately, this is a machine, AI generated, but you are the intelligent person behind it. So please do use your brains while you're doing it. When you're trying it, you may have failures, but it's the idea is to try because some people won't even try. And if you do not have your, TIVA TCI pumps, the best way would be to start with TIVA Trainer. These apps are freely available and you can start using them and they will tell you, at bit stage, once you put in your patient data the same way, and you will tell you what is the dose you should be giving it, and you can use the same data in a normal infusion pump. So that can be good for beginners. If you're starting off without a pump, you can use the manual infusion for the same. All these apps are freely available: iTiva, Serious Anesthesia, TIVA Trainer. So my take-home message is it's a result of more than 40 years of research. It's a very common practice, mature and a safe technology. As long as you have the right drug, right dose, right route, right time, and the right patient in which you're using. You all will undergo different phases of TIVA. When it first came in, I looked like this. I said, what the hell is this? when there was a demo done and I said, well, this works. When I started using it, I was really happy. And my happiness knew no bound when my hospital bought it and I started using it. And I have been very happy using it in the last 5 years that I'm here. The fight between inhalational agents as well as IV anesthetic is going to be a perpetual one. Our aim being to leave a green earth behind. We really do not know who the winner is, but in both the fields, I think both of them have their own pros and cons, and we need to work as as responsible anesthesiologists to leave a green earth behind for the next generation to come. I need to thank my team for being very patient with me in my journey of TIVA TCI in coronary artery and cardiac surgeries. And I thank you all for a patient hearing. Thank you.
Thank you, Dr. Kalpana. Please stay around. We will have plenty of questions. I think we'll take the questions after the Dr. Dheeraj's talk. Is that okay?
Sure.
So I think the Dheeraj is probably ready, and when he's ready, we will listen to him. A lot of questions have come up. I've noted down the questions, and we will see how best we can add clarity to every question which comes through the forum. Thank you, Dheeraj.
Yeah, sir. I will share my screen now. 1 second. Okay. Hello, all. Can you hear me?
Yes,
Dheeraj,
you are
we can
audible
hear
and
you.
visible.
Okay.
Got it.
If my signal is breaking at any point of time, please let me know so that I'll stop and so hello all. Excellent presentation by Kalpana madam. So I am going to cover about the brain monitoring, and so in this presentation I would be covering basically what BIS monitor looks like and how we actually use it, and then how the BIS algorithm works, and why we should actually monitor the BIS. And some people are asking questions, I can see in the comments, between TIVA and inhalation, which anesthetic technique will have more awareness. So these questions I would answer in the presentation as it flows now. So before going into the presentation, I would like to tell you that before you understand how a BIS monitor works, you need to understand something called as first principles of brain monitoring. So any subject you want to understand, you have to go to the root levels of how actually it originates. Only then you'll understand the nuances of that particular technology. I can just tell you that 40 to 60 is the number that you have to maintain, but it is not so simple. So you have to understand something called as EEG now. Yeah, sorry for the small. Yeah. So now basically what I would like to tell you is the EEG, what we actually record, or what BIS records from the electrodes that we place on the forehead, are nothing but the electrical activities that we record from the pyramidal cells which are present inside the brain. So the electrical activity which is produced in the pyramidal cells, the neurons, the pyramidal neurons in your brain, are actually caught by the EEG electrodes which are placed on the surface. So the EEG electrode becomes BIS when you keep on the forehead. So basically this particular electricity will cross several layers when it reaches the EEG electrode. For example, there are layers like pia matter, arachnoid matter, and dura matter. And after that, there is something called skull. And then you have scalp, and after that, a EEG electrode is there. So it has to cross through all these layers, and then EEG would be caught. So that is about how the signal actually goes up to the EEG electrode. And then you can see here, so you would have read about this neuron long back. I'll just try to brush up your knowledge a little. So what you're seeing on the screen is a neuron which will have a cell body and an axon. Okay, and there are something called dendrites on the cell body through which the neuron connects to adjacent neurons in your brain. So what happens is the EEG, what BIS catches, or EEG, what the electrodes catch, are nothing but the potentials which are generated inside the brain. So what are the different potentials which are generated inside the brain? We need to understand. There are two types of potentials which are generated inside the brain. So the first type of potential is called as an action potential. We would have read in our preparation time of exams and all that. There will be a wave like this. So action potential, resting membrane potential, and then after it crosses a threshold, then action potential will be produced, and sodium ions would go down, and repolarization, all that. So unfortunately, this action potential is very short duration, and it usually is restricted for a very small area inside the brain, so it cannot be detected by our EEG electrodes or the BIS electrodes. So then in such situation, then what is this BIS electrode catching actually from the brain? It is actually catching something called as the postsynaptic action potentials. Okay, I'll try to explain. As I told you, these cell bodies, what you're seeing here, the cell bodies, I'll try to show you with 1 second. So these are the cell bodies. So these are the dendrites which I told you. So these dendrites, actually between the dendrites of another axon, they form synapses. So these synapses actually will generate some potentials. These are called as postsynaptic action potentials. So these postsynaptic action potentials will have the capacity to cross the different layers of the skull, and they usually last for longer duration. Just 1 second, some technical glitches there. Yeah. So basically, these postsynaptic action potentials are the ones which last for longer duration, around 10 to 100 milliseconds. And these postsynaptic action potentials would actually cross different layers of the skull, and they are recorded by our BIS electrodes. So, for example, now here I would like to explain this particular concept with an analogy of a football ground. So, for example, a football match is going on, let us assume, and then a lot of people would be there inside the football ground which will be cheering for the match. And for example, if you are standing outside the football ground, then you wouldn't hear anything from the individual audience there, but what you hear is a combined anthem. If they sing, you will hear outside. So you can hear something like this. So these are called as anthems. So in the same way, what happens with the EEG electrode which is present outside is it cannot detect individual neuron postsynaptic action potential. What it usually detects is when a group of neurons or a cluster of neurons, when they generate signals in a sync, only those kind of signals will have the capacity to cross all the layers, and those are the signals which are usually be detected by the electrodes which are placed on the surface of the brain. So that is the comparison I wanted to give you. Here I would like to tell you another important concept before going into how BIS works. So people think that the EEG is actually produced by the cortex of the brain. That is absolutely true, but the pyramidal cells are located there, but it is regulated by two more important structures in your brain. Number one is called the thalamus. So thalamus is something like, if a football ground, if you take like a stadium announcer, for example, a stadium announcer would be telling when the crowd should cheer, when they should quiet down. In the same way, thalamus will actually decide what kind of signals should be relayed to the cortex, what kind of signals should be stopped, what kind of signals should be sent. So with anesthesia, this has a relevance. That is why I'm telling you all these things. So thalamus can decide what kind of waves will be produced in the EEG. And the second important structure is the reticular formation in the brainstem. Reticular formation has a capacity to either totally keep you awake or asleep. So it is the main part of the brain which actually which maintains the arousability of the brain. So these two structures will also indirectly influence the kind of EEG signals that we would be getting. So with anesthesia, I would like to compare and show you. So all these things I told you so that we can come to a point where we try to understand how anesthesia acts on these particular waves. So there is something called as a fast Fourier transformation. You would have heard this name multiple times. So fast Fourier transformation is nothing but when you send a bulk of EEG, raw EEG, through fast Fourier transformation, it usually divides the waves into individual frequencies. Okay, for example, a cluster of EEG, if you send through fast Fourier transformation, it will divide into faster frequency, medium frequency, moderate frequency, slow frequency. Slow frequency we call as delta. Moderate frequency we call as theta and alpha, and the faster frequency we call as beta, and there is super fast frequency also which we call gamma. So this division is done by fast Fourier transformation. So this also has a very important role in BIS algorithm, which we will deal later. So why I told all these things is the neurons, which the postsynaptic action potentials would reach the EEG electrode, and then the electrodes would be cut. So let me just compare and tell you how this particular anesthesia would actually how the EEG would be affected by the anesthesia. For example, if you're running TCI propofol, since already madam explained you about the TCI propofol, we usually start the TCI induction between 0.0 to 0.5 micrograms per ml. So when we start our induction at 0 to 0.5 microgram per ml, so what we usually say is the beta frequency. So that is the fully active frequency, because the thalamus or reticular formation are not actually inhibiting any kind of signals. They're sending every signal to the brain, and then all the neuronal activities are being detected by the electrodes. When we slowly increase the depth to 0.5 to 1.5 microgram per ml, then the thalamus will reduce the relay. So then the frequency of the EEG would slightly decrease, and it is called as an alpha frequency. Patient would be little sedated, but he would be understanding what you're telling. When you actually increase the TCI from 1.5 to 2.5, there's a further relay reduction from the thalamus and reticular formation. And then what happens is the frequency will even more decrease, and it will come to something called theta frequency. That is where moderate sedation would happen. When you want to induce the patient, then you have to take two planes where 2.5 to 4.5 is the target control level where you have to take, where the reticular formation also is suppressed. So when reticular formation is suppressed, then even thalamus also will be suppressed, and the kind of activity that you see in the EEG would be delta pattern. That is a very slow frequency pattern, and this is a surgical anesthetic plane that we target. If you further increase the TCI to 4.56, then there will be total shutdown of the reticular formation, and there will be something called burst suppression, which would be happening in the EEG. I'll show you the importance of burst suppression in the upcoming slides. So these are the different EEG patterns we see in different levels of sedation. A, B, C, D, E, F, you can see there. So A is awake, that is the beta frequency. It is very less in amplitude, fast in frequency. When we increase the sedation, as I told you, first paradoxical excitation would be there, a lot of spikes would be there like epilepsy, and then you will have the sedation phase where you would see the alpha frequency. And when you increase the depth some more, you will see something called a surgical plane, where you would see a wavy pattern. So there will be alpha and delta pattern. And then you would see something called as burst suppression when you go very deep. That is the last F pattern, where the isoelectric line would be there, followed by a burst of electrical signals. That is the depth which we don't really want. We want to keep the patient in the level D and E, preferably. So D and E are the patterns that you need to target when you're actually analyzing the wave in the BIS monitor. So with this information, let us start monitoring the mind and elevate the standards. So let me tell you some of the statistics of usage of BIS in India. So in India, actually, the usage of BIS is significantly less. 15 to 20% of tertiary care centers only are using. So most of the hospitals don't use BIS. So let us compare this with the developed nations, and let us see in USA what is happening. Up to 80% of the hospitals are using BIS. Okay, and then in UK, around 60 to 70% of the hospitals are using BIS because the regulatory bodies and guidelines, particularly the NICE guidelines in UK, is recommending the usage of BIS. So, but most of the centers are using BIS. So this is where we're lacking behind. So what is the reason? The reason that is found in studies is that the cost of the equipment is one of the factors. So many people will have issues requesting the management and hospital to buy the BIS monitors. But nowadays it is just an extra module connection to your Mind or GE monitor. It wouldn't be a major issue. And lack of awareness and lack of awareness in the sense it is more about if you use regularly, you understand how useful it is. Everybody knows the number between 40 to 60, but if you are regularly using it, it is a very beautiful monitoring technique. So all these numbers I got from these particular studies. So let me tell you a story here about Miguel. So Miguel is a writer, and he has won so many awards for his writing, and lot of Hollywood movies also he has written. Okay, and I think his Oscar nominee, something is there like that, and he's one of the famous writers. So what happened is he developed, he went for a surgery, and then during the surgery, what happened is after the surgery, he lost his ability to write the stories. So basically, he lost his livelihood. So this is what he has written: the operating room erased me and left me afterward. So what he is trying to tell is, after he developed his skill of writing the story is what he lost. So his livelihood is what he lost. Like that, there are so many stories actually where if you don't keep the depth adequate, then these kind of problems can happen. This is all this will come under the umbrella called as post-operative delirium. There are different definitions to it, but so post-operative cognitive dysfunction is usually a kind of a brain. It's a kind of a brain disease which usually happens 1 to 3 months later, not immediately. What you see immediately is called delirium or post-operative delirium. That is actually okay. But this post-operative cognitive dysfunction is a more dangerous disease if you really affect the area of the brain which is livelihood for that particular person. So there are several implicating factors for this, like advanced age and long duration surgery, blood loss, and all that. But burst suppression is an very important factor which can lead to this POCD. So the longer the duration of burst suppression, usually they say more than 20 to 30 minutes of burst suppression, if you keep in an older adult, there is a high likelihood that he would develop post POCD after a few months. So you can see here pre-surgery clock drawing would be normal. Okay, so if you tell 11:10 they would draw. So, but the same clock drawing post-operatively, some people wouldn't be able to do. Okay, the reason is they developed POCD. Then there are studies done and they try to identify what is the exact problem here. What they found is hippocampal volume loss is seen after general anesthesia. So the medicines that you're giving, don't think that they are very safe medicines. The medicines that we are using, if we don't use in correct doses, we would actually lead to the damage of hippocampus. That is where your memory is saved, your emotion. It's a part of limbic system, no? So your emotion, your memory, and logic, and all these things would be there. Okay, so with this introduction, let's enter the BIS monitoring. So you want to know more about the BIS, I know. So BIS is actually developed by Aspect Medical Systems, and then thousands and thousands of hours of EEG has been analyzed with fast Fourier transformation. As I told you before, fast Fourier transformation actually divides the waves into different frequencies. So the BIS algorithm, they haven't released for many years, but now they have released the algorithm, and I'll tell you how actually BIS gets the number in this presentation. Before going into the BIS algorithm, I would like to tell you 0 to 100 is a scale, and then 0 is the deepest part of anesthesia. That's a flat line. Okay, EEG, isoelectric line is what it is called. 100 is the awake state. If we connect for ourselves, it would be 100. And between 40 to 60 is the recommended range for general anesthesia. And I keep between 40 to 45 or 35 to 45 since I don't use muscle relaxants for my cases due to neuromonitoring purposes. Okay. And then let's go into algorithm. There are 3 main elements in the BIS algorithm. The first element, algorithm in the sense on what basis BIS gives the number is what I'm trying to tell you now. Okay, number 1, element it is going to consider is called as relative beta ratio. Relative beta ratio is a key indicator for anesthesia depth assessment by BIS algorithm. Normally what happens is there are two types of frequencies, okay, in beta, mid frequency beta and higher frequency beta, okay. So relative beta ratio is the ratio between the high frequency beta to mid frequency beta, okay. So as the anesthesia depth increases, what happens is the higher frequency beta would decrease and mid frequency beta also would decrease, but the decrease of the higher frequency beta would be more than the decrease of mid frequency, so the ratio would actually decrease. So when this monitor understands that relative beta ratio is decreasing, it will indirectly understand that depth is also increasing. So that is how it actually gets the value of that 40 to 60. This is one of the metrics. There are two more metrics which I am going to tell you now. Hope you understood. The second concept is called a sync fast slow. Okay, sync fast slow is the concept. So here what happens is there are two frequencies of EEG. One is called as a faster EEG wave, which is called as a gamma frequency. Okay, the gamma frequency is above the beta frequency, that is like above 30. So this particular gamma frequency is always coupled with the slower EEG frequency. So the coupling usually happens. So this coupling is very complex and it is mediated by cortex, thalamus and reticular formation. So this particular coupling is decoupled when you give anesthesia. So there is no more synchrony between the fast and slow. So when the machine understands that there is a desync happening between the fast and slow frequencies, then it will assume that the anesthetic depth is increasing. This is called a sync fast slow. The sync fast slow is nothing but there is a sync between fast waves and slow waves, which is present during the awakened state, and in the deeper planes of anesthesia, the sync fast slow will decrease. So even with that, the machine will understand that the patient depth is increasing. And the third important metric that it will consider is something called as a burst suppression ratio. In some of the machines, you actually see that number. So burst suppression ratio is nothing but it is a ratio between the suppressed part of the EEG. So here what you're seeing is a burst suppression pattern. There will be a flat line followed by a burst of activity. The suppressed part of EEG, if you divide with the burst, duration, the duration of suppressed EEG to duration of burst, if into 100 is the burst suppression ratio. For example, in a 60-second time frame, 30 seconds EEG is burst and 30-second EEG is in the, 30-second EEG is in the isoelectric line and 30-second EEG is in the burst. Then the ratio would be 50%. So when this algorithm detects that burst suppression ratio is some 30 or 40, so burst suppression ratio would be the strong influencer of the BIS number. So the relative beta ratio and sync fast slow, it wouldn't consider at that point of time. The machine is designed in such a way that it will only consider the burst suppression ratio in getting you a number. So that is the importance of burst suppression ratio. For example, if you're seeing a BSR of 10% on your screen, then the machine's number is largely derived from the burst suppression ratio rather than the relative beta ratio and sync fast slow. If burst suppression ratio is 0, then the number is actually coming from either relative beta ratio or from the sync fast slow components of the algorithm. So this is how this algorithm is designed. And Aspect Medical System hasn't released this algorithm for many years, and later on they have released it because I don't think there is anything to lose for them. After certain years, they would have made their money maybe. Another important concept that you need to understand is called as anti-realization of alpha concept. I'll tell you this is another beautiful concept. So what happens is when a patient is awake, most of the alpha frequencies are located in the parieto-occipital area. So you are seeing here. So I will show you. So this is here you can see my laser pointer. These are the red color you're seeing. This is the alpha frequency. In awake state, in human brain, alpha frequencies are located in the parieto-occipital area. So when you start giving anesthesia, these alpha frequencies will shift to frontal area. Here, see, it is shift from anterior. And when you reverse the patient again, it will come back to parieto-occipital area. So this is another way of estimating depth of anesthesia. So basically, if you are putting an EEG in occipital area and frontal area, you can see the shift. We have done that in the MANS. You can actually see the shift of EEG happening from the occipital area to the frontal area. This is one of the ways to understand whether your patient is in adequate depth or not. Let's come to the BIS. So BIS electrode actually will have 4 components to it. So electrode, so you can see there 1, 2, 4 and 3. So basically there are 4 electrodes, right? All 4 are not recording. That is what you have to understand. So number 3 and number 4 are the only active electrodes in the BIS electrode. And BIS sensor will have only 3 and 4 are active. Number 2 is reference and number 1 is ground. So reference is, the reason reference is there is because any electrophysiological wave, you take any wave in the body, come EEG to EECG to whatever, EMG, it's a potential difference between 2 points. So when you have an active electrode, you always need a reference electrode. The potential difference between these 2 points is actually seen as a wave. Got it now? So that is why you always need a reference. And then you also need a ground, because every instrument in your OT is generating electricity. Your fan, your lights, your monitors, your warmer, even your table, which has electric connection. All these are actually producing electrical artifacts. All these are actually nullified by your ground electrode. So only if the ground electrode contact is good, you would see a proper EEG which is coming from the neurons of your brain. Otherwise, it will be contaminated by all other electrical activities. That is why number 3 and 4, you have to make sure that they are actually touching the temporal part of your brain. Some people actually keep your BIS somewhere lower side, that you are actually catching the signals from the maxillary mandible, which we don't really require. 3 and 4 are the active electrodes. They should be on the frontal and the temporal areas. So when you are placing BIS, first thing that you need to do is you have to clean the surface of the forehead, neat, with sterilium or a gauze. So make sure you rub properly, so that there is a layer of keratin on your skin, which is which don't conduct electricity. It is called a poor, it's an insulator basically. It's a poor conductor of electricity. It doesn't allow the EEG signals to cross through different layers of your, which I explained before. So you put all the, I think some of the electrodes will come with small, kind of a device where you can actually clean properly, and the keratin layer can be removed. After that, you have to dry it and then attach the BIS electrodes and then neatly secure it. You can see on the screen. So number 1, 2, 4, and 3. So 3 and 4 are the active ones. And once you get a screen like this, don't directly jump and see the number. Before you see the number, what you need to see is something called a signal quality index. So signal quality index is how good the contact is. So there is something called as impedance. Impedance is basically you are connected an electrode, right? So that electrode, if it is in good contact with the surface, then there wouldn't be any resistance for the electric current to pass from the skin to the electrode. So if this resistance is increasing, then impedance value will increase. So up to 5 kilo ohms is what is generally acceptable. If it is crossing 5 kilo ohms, then that sensor would fail. To do that, we would do something called a sensor check. This is called as a sensor check. So when you do a cyclic check or sensor check, whatever you call it, all the 4 are ticked here. So I think all the 4 are passing the test of 5 kilo ohms. It is less than 5 kilo ohms. So then once the test is passed, signal quality index would automatically be above 95. So I recommend a SQI of around 90 before you interpret the number. This is one of the main metric that you have to see. So the next important metric is the EMG that you are seeing on the screen. You can see here, this is the EMG. Normal value is around 25 to 30 under anesthesia. It cannot be 0. If EMG is 0, that means patient is dead, because only dead muscle wouldn't generate EMG. Any living muscle, even under muscle relaxant, would generate EMG. So EMG around 30 is fine. If it's crossing 45, you have a serious problem, which I'm going to tell you what later. So next important metric that you need to understand is called a spectral edge frequency. Some of the machines are also giving this metric called spectral edge frequency. It is a very simple metric. The name looks complex, that's it. So spectral edge frequency is nothing but it is a metric where 95% of the EEG frequencies are below this particular number is what it is going to tell you. For example, the image you can see, the first image, spectral edge frequency is 27. This is awake state. That means 95% of the frequencies, SCF 95 is the number, 95% of the frequencies are below the frequency of 27 in awake state. So why is this useful? I'll tell you now. And when you give anesthesia, the frequency would become slower, right? So 95% of the frequencies would fall less than 12 to 13. Here in this image, it is showing as 16. That is pretty decent. So when your spectral edge frequency 95 value is less than 12 to 13, that means your patient is in a good anesthetized plane. Okay, this is called as SEF 95. So some people, get mistaken. They will think BIS value is actually 3 times the SEF 95. That's a myth. That is not real. BIS value is actually coming from the algorithm, which is so complex, which I explained you all this time. And SEF 95 is a totally different metric that will tell you what is 95% of power lying, or 95% of frequencies are actually lying under what number. Okay, so this is about the BIS. Next, let's go to the EMG, a very interesting concept. So before you read BIS, you have to understand what EMG is. So EMG is nothing but the activity generated by the frontalis muscle, which is exactly located where you are placing your BIS sensors. So since you cannot, as I told you, every living tissue generates electric potentials. So this frontalis muscle would generate the electric potential, which will have very high frequency, and it can cause artifacts in the BIS. Okay, we have to make sure that the frequency of EMG is less. How do you make sure? Keeping good plane of anesthesia, good analgesia, and good muscle relaxants. If you give all these three, then EMG will be under check, and then the BIS value, what you see, is reliable. If you don't, so here you can see what is happening is BIS is measured between a frequency of 0 to 47. Between 30 to 300 is where EMG lies. So this slice of a pie, 30 to 47, is where intersection is there. So where EMG can directly affect the value of BIS. So if patient's EMG is high, then falsely you'll see a higher BIS. That doesn't mean patient needs more sedation. That means patient either needs a muscle relaxant or analgesic. So you can see here when the EMG value is going up, red color line, the BIS value also is going up. So BIS is not only useful for maintenance, it is also useful for extubation. I extubate every patient on BIS. My hospital, every patient, BIS will be there. Since I use TIVA, somebody was asking a question, no? Between TIVA and inhalation, which will have a higher awareness? I'll tell you that after some time. So see how I extubate basically is, see here I'm saying 68 number. I will not disturb the patient because that is not the plane which I want. I'll wait for another 5 minutes. Once I get 75, still I will not disturb the patient. I'll wait for another 2-3 minutes. Once I get to the plane of 80, then my time has come. I'll just call the patient's name. So patient will open eyes, comfortable, and we can extubate after that. Maybe 1-2 minutes down the line, he'll start obeying. No bucking would be there in that plane. Bucking usually happens when you wake up the patient in a BIS of 60 to 70. That is a delirious plane. They will only buck. They won't understand what you're telling. In neurosurgery, a big no. Okay. Maybe in other cases you can try. So, but for that you should have some luxury of having some time for extubation, which I usually have because neurosurgeons usually understand the importance of extubations. There are certain limitations for BIS. Children, it is not validated below 6 months. Hypothermia, big no. It won't come because hypothermia will decrease the metabolism and then brain activity would get suppressed. Neurological disorders will have a very low baseline BIS to start with, so you can't monitor the depth there. This is one of my studies where I measured BIS in head injury patients, and I found that to start with itself is 46 in severe head injury. So what BIS will measure? So we cannot do. These are some of my articles where I published the artifacts of BIS during different types of neuro monitoring, like facial nerve monitoring, DWAV monitoring, and complex spine surgeries. So all these monitorings would cause artifacts in the BIS, and falsely you'll feel that BIS value is higher. You'll end up giving more dose, but these are the actual artifacts which are produced because of the monitoring. And coming to guidelines, NICE guidelines recommend BIS monitoring. So NICE guidelines are the guidelines followed by UK. And in if you're staying in UK, you have to follow NICE guidelines. If you're staying in other parts of the world, maybe even if you don't follow, nothing will happen. But in UK, if you're practicing, you have to follow. There is no option. So NICE guidelines recommend BIS monitoring. That is where their utility is around 80%, 60 to 70%, I think so. So this finishes my presentation on BIS. In 5 minutes, I'll finish my talk with covering entropy because GE monitors are coming with entropy, and entropy is nothing but the algorithm of entropy tries to understand the disorder in the system. What they assumed is if the irregularity is more, entropy number would be high. For example, when you're awake, there is a lot of irregularity in your brain, so entropy number is actually higher. When we give anesthesia, the brain becomes calm, and then the entropy number actually comes down. That is a basic, thing behind the algorithm. So what you need to understand is there are two elements of entropy. One is called as state entropy, other one is called as response entropy. So why Entropy came into the market is when BIS is already there. There is a element of EMG contamination in the BIS, which is very difficult to understand if you're not an expert. So response entropy and state entropy made that job very easy. I'll tell you how. So response entropy gets a number between 0 to 100. That number is measured between a frequency range of 0.8 to 47 hertz. Okay, so in the response entropy range of EEG, there is EMG contamination. So state entropy is another number which the same machine gives, which measures the frequency range between 0.8 to 32 only. So as I told you before, EMG starts from 30. So the bottom line is in the state entropy value measurement, there is no EMG contamination. So Aramse, you can see the state entropy number, and then you can be pretty sure that you don't have EMG contamination, that you can titrate your anesthesia based on the state entropy number. Then if you ask me when state entropy is there, why do you require response entropy again? It's a time waste now. So why response entropy is there is when they're making the algorithm, what they understood is, you can see here, there is some gap between state and response entropy is always higher. And this gap is changing at different phases of surgery, and then they try to analyze why that gap is changing at different phases of surgery. And what they found is the gap is largely changing based on the analgesia. The phases where patients analgesia level has come down, the gap is actually increasing. So whenever they started supplementing the patient's analgesia with opioids like fentanyl or remifentanil or morphine, the gap is actually decreasing. So now they are using it as a metric to understand if patient needs more analgesia, even though there are no anti-nociceptive index and all that, and even Conox also gives you analgesia, but this is a simple way of understanding. Entropy also is simple. It is placed like only 3, like ECG 1 to 3 you connect. Two are one is active, one is ground, one is reference. Okay. So this is how the screen looks like. Response entropy and state entropy would be there. So these are the two numbers that we get. And if you ask me which is the best monitor, Massimo's headline is what I'm liking. The reason is it is a different type of monitor. It measures something called patient state index. And in patient state index, what happens is the assessment values are slightly different. In BIS 40 to 60 is the surgical plane, but in patient state index 25 to 50 is the surgical plane. What you're seeing here on the screen, 25 is a okay depth when you're using patient state index, but it might be very less when you're using BIS. And the second important advantage of headline is it's a 4-channel EEG. BIS and Entropy are one single channel, but 4-channel advantage is that even if one channel is not working due to resistance or increase in the impedance or the contact is not gone, the rest of the 3 channels can get you a number. So you have high probability that you get BIS throughout your surgery. This is how a headline looks like. Okay. So take-home points are follow the EEG trace along with the number. Okay, if you're seeing at the number, then understand what is a good signal, and signal quality index is what you have to see before interpreting the number. In EMG values also you have to see. And entropy can help you find nociception also along with the depth. Okay, so that is about different types of neuro monitoring. And I have observership in my hospital in Astor Whitefield, Bangalore. If somebody wants to come and learn different types of neuro monitoring, you can stay with me for a few days to a week, and we'll give you a small certificate in the end. Thank you very much.
Neeraj, a wonderful exposition on this topic. Thank you. We all had a wonderful time. Kalpana, we both of you have given a wonderful talk. If it's all right, I'll go on to a few questions. I'll start with Dheeraj first because that seems to be the hot topic. We'll come to you. A few other things. Now, first question about this was, is depth of anesthesia monitoring relevant only for TIVA or for other volatile anesthetics as well?
So I will tell, as I didn't tell the answer to the question. One person actually is asking the difference between awareness between TIVA and inhalation. After that, I'll tell you this answer, sir. So there are so many studies done actually. There are landmark trials called Be Aware, Be Unaware, and even there's a national audit of UK 5, and it's called as an app 5 project. So all these things are there, but there are very few studies comparing directly between TIVA and inhalation, which has more awareness. But most of these studies and audits and everything have proven that awareness is slightly more in TIVA compared to inhalation. So the main reason being the usage of depth of anesthesia was not there in those cases. Because of that, the awareness was slightly higher in the TIVA group. But even there is only one study directly comparing. Even in that study, the awareness is more in the TIVA group. But most of those studies, they didn't keep depth of anesthesia as a standard, so they didn't use that. Maybe that is the reason, is what I feel. Coming to, is it mandatory or not? So when studies are clearly showing that there is increased awareness in TIVA group, I think it makes sense to monitor not only for awareness. Most of the times it is not the awareness that is the problem. It is the too much depth that we create. So when I regularly do use BIS for thousands of cases, what I understand is most of the times we create burst suppression without our knowledge. That too, when the BP slightly decreases to 90/60, even that also will contribute to the burst suppression. And significant durations your patients in burst suppression, which might lead to POCD, which we don't usually assess since it happens after 2 to 3 months.
I'll just extend a little bit and go to Kalpana for a second. Now, you mentioned in your slide that depth of anesthesia monitoring is nearly 80% in the US, where TCI is not so popular. So
Yeah.
does it explain something about the requirement of depth of anesthesia monitoring?
That is, yeah, if TCI is there, you can partly be sure, because if you keep around 3.5, 3 to 3.5, you can be pretty sure that patient is in good depth of anesthesia. But if you don't have a TCI pump, when you're running manual infusions, there is no other way other than using depth of anesthesia. That is why maybe in USA they're using it 80% is what I feel.
Now, is that only for TIVA, or they are using it for volatile anesthetics as well?
They are using for volatile also.
Yes, that's what I wanted to come out. I think that overall 80% is not 80% of the TIVA. I think it's 80% of the general anesthetics they are using.
Yeah, exactly. Correct. It is 80% of the whole anesthetics.
That's right. That's what my understanding.
Yeah.
If I may say, there is an article which is showing a head-to-head comparison between inhalational anesthetic and intravenous anesthesia in a US paper, which mentioned about the use of BIS. And it showed that how we were overusing the anesthetic agents in both the vapor group as well as this by the BIS study, and showed that the postoperative cognitive decline and the delirium was much more in the group in which the BIS was not used, whereas they could decrease it much in where the BIS was used.
Kalpana, I welcome back here. Now, it was a wonderful talk. Just want to explain to all of us here, why did you move from volatile anesthetics to TIVA? What difference have you found while using TCI? Even in cardiac, which is probably the slowest specialty to adapt, you have adopted it, and you're using not just a propofol, you're using remifentanil. You probably are using dexmedetomidine in your cath labs, etc. Why? What made you change? Why? How do you find it?
I think my main thing which I found was post-operative, my patients were, see, I was anyway doing a lot of fast tracking and ultra fast tracking. And when I compared head to head, when I was doing that with inhalational agents vis-a-vis that with TIVA TCI, I did find that my patients, I mean, they would wake up as if they've just gotten up from sleep. They had no post-operative nausea, vomiting. There was no retching or anything. And in fact, I'm just finishing my statistical analysis of both these groups, but I do find very encouraging results where I have used TCI and I've been able to ultra fast track more patients on TCI than what I have been able to do with inhalational agents. The other thing is that with Dexam and maybe using adjuvants, I think my use of beta blockers and problems with beta blockers have kind of completely gone away. I do not have to use boluses of beta blocker to control the heart rate, because we are mainly doing coronary on beating heart, where we need to maintain the heart rate and the blood pressure at a desired level for the surgeon to work with. So with this continuous infusion, it has made my life really easy. So that's the reason why I have used it. I found a lot of advantages over using Lullaby when I was using inhalational agent. Apart from that, even myocardial depressant effect, which I was finding with inhalational agent, was much less with my TIVA TCI group.
Wonderfully answered. I mean, I also feel, both of them are going to sleep. With TIVA, you wake up as if you are refreshed sleep. And with generally with volatile, you wake up a little bit, uncomfortable sleep. Also it depends on the analysis as well. Like I do account for it. Now the next questions is something which you can easily answer. What are the brands of TIVA pump, TCI pumps available, and which one would you recommend, or which one is good?
So we've got BD has got Alaris pumps, Nexus Alaris pumps, which has got the latest Eleveld model. So that's a really good pump on which I'm using it. But I'm awaiting to get an Acromet pump, which has got all the models and again very user friendly. I believe Fresenius is now coming up with an Eleveld model shortly. They don't have an Eleveld model as yet. So these are the three pumps which I have been exposed to: BD, Fresenius, and Acromed. If you're asking my personal, what I have used it, I've used all these three pumps, but I'm right now currently using BD Alaris.
Dheeraj, what about your
So I used BD Alaris in my previous hospital. In the present hospital, I'm using Arcomed pumps. I'll tell you the difference is that it is how many models are there in the pump will matter basically, and robustness of the pump. So these two are the most important things. So Arcomed has almost like 14 to 15 models incorporated. It's not only Propofol or Eleveld, it is all like you can fentanyl is there. I have ketamine TCI, midazolam TCI, and then there is remifentanil TCI. So I have like 2 studies are going on in my department with ketamine TCI. Okay, so I need more a number of models actually. So 14 to 16 models are there. That many models are not there in other pumps. So Arcomed is what I chose in the new hospital. So all are like Arcomeds.
From what I understand from both of your discussion, so what is important is it's not only for Propofol, you can use it for other drugs as well, and that other drugs include Propofol, remifentanil, ketamine, midazolam, dexmedetomidine, fentanyl, remifentanil, and all these drugs are there. Depending on where you want to use, for what you want to use, if you have a pump which has got all these models, it would be beneficial. For example, if you want to cover endoscopy or cath labs, you might want to have a pump with all these additional models as well. But in the OT specifically, so the newer models have an advantage because they are general purpose models. As Dr. Kalpana was telling, this general purpose model has an ability when you can use it for entire age range from neonate to the elderly. Is that right, Kalpana?
Yes.
So, and Dr. Dheeraj,
Yes.
now, a lot of us used to just focus on the numbers, on the BIS numbers. So, are we moving towards a time zone wherein which all of us will be able to read, just like ECG, they read the pattern and understand the depth? Is that is possible for all of us?
It is 100% possible, sir. So as I've shown you, actually I didn't focus much on the wave interpretation, which I do in my workshops usually. So the way in different depths, I've shown different types of EEG waves. The depth where you see alpha and delta, there's a wavy pattern, is what is our desired plane. So that wavy pattern, if you get, irrespective of the number, your patient is unconscious or he is in a very good depth actually. So that is the target. I don't see the number now. I'll see whether the wave is on a wavy pattern or not, because number is prone for artifacts. Number can be influenced by EMG, number can be influenced by so many other things. So looking at the wave and understanding would be a right way of understanding. It is very much possible. You just have to see number of hours you see the EEG matters for that.
So it's not just for a neuroanesthetist, for every anesthetist. If we look at the waveform, just like how we identify different ECG patterns, it is possible for us. And is there any recommendations of where we can study, where we can look at examples are there? If it's possible, can you share with the group so that we all can look at the waveforms in action?
Yeah, there are certain review articles, sir,
Hmm.
where like 1 or 2 review articles are there, EEG in anesthesia and all that. So they have written in depth about what exactly whatever I spoke today, like that. So some review articles are there. I'll share to Kalpana madam. She can share to the group maybe.
Kalpana, earlier, when somebody had put a very interesting question. Now, whenever there is sudden changes in the blood loss, or blood volume, or blood pressure, uh, is the compartments, does it get affected? If so, how should we manage? And how should we look into that kind of scenario?
Yes. So if there's a so say a trauma patient is coming, or a patient is bleeding a lot on table, you need to decrease your target concentration, because your V1 compartment is going to go down. Especially if you're using an Eleveld model as well, your V1 compartment will go down. So please see to it that you titrate yourself up, or if you're having a hemorrhaging patient, you're not taking up and doing it on a TIVA TCI. Do not start off with your target concentration of 2 or 2.5 or 3, which is a set target. You need to see to it that you start with a low this thing, and of course at the same time you're going to build up the volume loss which you have had. So as I mentioned, the clinical situation, the characteristic of the patient is very important when you are titrating your drugs with TIVA TCI.
I think we got the answer from you. So just like even if you're giving a volatile anesthesia, so you would not keep the same MAC concentration when you have either a sick patient or a patient with a trauma. So you will understand that the scenario has changed, and you will try to try the same thing you would like us to do. Is that right? Did I get it right?
Correct.
So, and especially here, because the circulation are, between the central compartment and the peripheral compartments can be affected, the redistribution can be affected. So we have to be a bit more watchful. And that is where probably I personally feel, what do you think, Dr. Dheeraj? Is that the scenarios where EEG will be more useful for us?
Yeah, exactly. I was about to tell that. So I usually, what I do is, for all the low ejection fraction cases and all that, I connect BIS first when the patient is awake, get the baseline value between 90 to 100, and then slowly start the TCI between 0.5, slowly at 0.2 increments I'll be taking, sir. So around 1.5 to 2 or somewhere, the BIS value would come to 30 to 50 somewhere. That time I'll just give relaxant. You don't have to wake up the patient also.
And Dr. Kalpana, on a typical case, how do you run the infusion pump? I mean, how do you set and how do you go about? What targets you start off with and go about?
So say for an ASA grade 1 patient, and if I'm going to put in my lines in the patient and awake, because I do mainly coronary, so if I'm putting my lines under local, I would start a remifentanil infusion. Of course, I'm oxygenating the patient, and I start my remifentanil, put all my lines in that, and then I start off with my propofol, titrate it upwards, start off with 0.5, increase it to 1, go slowly up. And once I find at what concentration my patient has lost, he's lost his verbal contact, verbal command, and I'm able to ventilate the patient. And then I would like to give them a muscle relaxant and then do some airway manipulation. At that time, if I find that my vitals or my hemodynamics are going high because my patient may be a hypertensive, and has a response, sympathetic response, then maybe I would increase my target concentration, or maybe my analgesic or remifentanil component as and when required. And then once intubation and everything is done, then of course we reach on a steady state and then maintain it according to like maybe at a sternotomy, I need to give a little more. But once sternotomy is done and then we are just doing the mammaries and, doing the anastomosis, generally I maintain it at between 1 to 2. I have never gone beyond, 2.75 to 3 was a very rare case which I have done. An Indian patient, as you all might know, that Dr. G.D. Puri had done a very good study on the Indian patients, even in coronary surgeries, and they found that Indian patients do not require more than 2.5 to 2.7 as a target concentration for propofol. So that's what I do. But when I'm using remifentanil, we must remember that it's not a very it's a drug that I would once I would stop, the patient would have will be devoid of any analgesic effect. So 20 minutes before stopping it, I would like to give some multimodal analgesia to the patient and then stop the propofol, take the patient into the intensive care, wait for an hour and see if there's no blood loss, no this thing, I would extubate my patients.
Wonderful. Dheeraj, I'll get you into here. So
Yeah.
you have mentioned on and off there about some component of pharmacogenetics.
Yeah.
Now, are you aware of any studies or any gene which you are heard of or you want to share
Yeah.
with us?
Yes, sir. There is a study which is published in Nature journal a few years ago, and Nature is one of the top journals in the world. And what they published is there is a variant there is a mutation possible in around 8 to 12% of the population. That's a significantly high number. It's called 5-HT2A gene in the body. So this particular gene is responsible for metabolism of propofol. So this 8 to 12% of people who have a minor mutation of this particular gene will metabolize propofol in a little slower way. So in these people, you might overdose them. I mean that the requirement of TCI would be less for these people. So that is one of the reasons why you need to monitor the depth of anesthesia, because and this has been published in Nature journal also.
So I thoroughly agree, because we have all seen that the sensitivity of the patient for each drug is different. With propofol, sometimes the same weight category patient might go to sleep with less than half the dose if you're given it slowly and observed it. I thoroughly believe that there is some component of pharmacogenetics which makes people, especially the Asian races, a bit more sensitive to propofol. I don't know whether, but other drugs also, we probably will have an answer. There are a few other questions which have come. Now, effect of muscle relaxant on BIS value. What are your thoughts?
So muscle relaxant will not have a direct relation with the EEG of the brain, but only thing is when you keep the patient in a good depth of anesthesia, good muscle relaxant plane, the EMG component would be nullified. So without artifacts, you get a real number. So there is a study which is done long back where they given muscle relaxants to volunteers, and they found that there is a 30% drop in the BIS. But I personally don't totally agree with the results of that particular study, because in that study, what would have happened is the contamination of EMG on the BIS would have been eliminated. That is the reason they would have seen a lesser value, but directly muscle relaxant will not have a effect on BIS number. But if the BIS number is falsely elevated by the EMG, and in that patient, if you're giving muscle relaxant and decreasing the EMG component, then logically BIS value might come down, or you'll see a real value of BIS. But here again, one more element is there. I personally see that whenever the EMG is increasing, they respond to fentanyl or opioids better than muscle relaxants. When I give opioid, the EMG actually becomes calm and it will decrease in number, and I get to see the real value of BIS. So rather than increasing propofol TCI, you have to actually see the EMG and give analgesics at that point of time. So this is my take on muscle relaxants and EEG.
Dr. Sunil has asked, when you're using multiple drugs, Dr. Kalpana, you can take this at one time, then you need more than one pump at the same time. What about the cost?
Yes, the cost can be prohibitive, but you definitely require more than 2 pumps if you are going to use multiple. But the other thing is that maybe you can use it as, put it in TIVA and use it as a manual infusion if you want to use it. So that is another way that you can cut down the cost and do it.
Especially I personally feel if you're not modifying it too much, you're trying to achieve a steady state. For example, if you're using a dexmedetomidine, you will not going to change too much. So you can achieve a target level of 1.5 nanogram or 2 milligram and stay at that. So, and then that can be easily managed with ITIVA app and a normal infusion pump. I personally see there is probably 2 kinds of expenses. One is capital expenditure and running expenditure. CapEx, once it is done, it stays for 100 patients, 200 patients, or 2000 patients also, as long as we maintain it. So I don't think it's an increase. It adds cost to individual patient, but to establish it, it probably will need some amount of expenditure. For example, the modern vaporizers also cost a similar thing, isn't it? Now, Dheeraj, you want to see? What's
Yeah,
the
but the higher value of EMG will accept, so correct. So the EMG, say some machines are coming with some 4-5 bars on your screen, some machines are giving a number. So if you're getting to see the bars on your screen, you please make sure there is not even one bar on that. To try to give either first give opioids and then give relaxants. And the second number, if I have to come to number up to 30 to 33, up to 35 is fine. Less than 30 is better number for EMG. That is the frequency, what I'm talking about. If it is crossing 40, 45, the value of BIS that you're seeing is falsely higher. Please don't rely on that. If you want the correct value of BIS, then you have to get the EMG to less than 30.
I think we have sort of answered most of the questions. Open forum, Dr. Yogita, Dr. Sona.
I think there's a question which says, is any reports of awareness despite of a good BIS value of 40 to 60?
There are few reports despite of keeping the BIS between 40 to 60, so that there is a bag recall major trial also done. So in that trial, what they found is even in the BIS group there were some awarenesses reported. There's a that's one of multicentric trials done long back around 2006 or 2007. So there are systematic reviews also done. Even in the BIS group there were awarenesses. But the thing is, if you between 40 to 60, what I feel is between 40 to 50, if you keep, you can be pretty sure that your patient is under anesthesia. Because none of my patients are aware, because I regularly check Michigan awareness score the next day.
Any gold standard for depth of anesthesia monitoring?
I mean, the type of machine, BIS is what I use, and Entropy, so gold standard, if you ask me, Massimo Sedlan is what I really loved when I used it on a demo, but it's pretty expensive. It's almost the cost of anesthesia machine. But the thing is, most of the monitors are coming with a module attachment of the BIS. If you're using Mindray, you get BIS by default. GE machines get you Entropy. Like that, Entropy and BIS, both are pretty decent, is what I feel. BIS is what I personally use.
One last question, if I may ask you. We've all seen after giving a spinal anesthesia, so patients usually get sedated. They
Yeah.
automatically sleep off. Their
Yeah.
mind sleeps off. Now, people do get worried if you relaxant is given, the BIS has dropped. Is it something like differentiation also happening? Does it have an component wherein which it can drop the BIS value?
Which one? The relaxant part you're talking, sir?
The relaxant part.
So the relaxant part, there is a study I told you, so in human volunteers, they just gave relaxant, succinylcholine, and they saw the BIS value came from 100 to 70 in most of the people. So I'm not getting convinced with the study results. That's it, because maybe the 100 value of BIS, whatever EMG component is there, that part is getting decreased. But logically, neuromuscular junction when you block, the signal which is coming from the pyramidal neuron cannot get affected.
One final comment from you, Dr. Kalpana, recommendation or comment from you?
I mean, I would just say to the beginners who would like to try this, I think just jump into it. It's not, it's not something very difficult to work with. Get used to the ITIVA app, and that will kind of help you to use it with your manual syringe pumps that you have till your hospital gives you a infusion pump. And maybe start off with an ASA grade 1 patient, simple cholecystectomy, simple hernias, start off with these patients rather than jumping into, ASA grade 3, grade 4. And as you move ahead, everybody will get the confidence to go ahead. And of course, members of IOTA are there to help you all out at any given time. I'm sure Dr. Subramanian will agree to that.
That is true. Any of the IOTA members here, we are happy to help, and it will, you can all meet us as well, and on the workshops or in the national conference, which is being planned very soon. And I can't thank you both enough, and the ISA Mumbai Metro branch, Dr. Yogita, and all of you there. I'm really thankful to you for giving us the opportunity, for our wonderful speakers, and also for IOTA to come on platform. Thank you very much.
Thank you all. Next time, I think we should have an offline meeting in Mumbai. We would like to meet you all in Mumbai.
Actually, we have a state conference in October, and TCI TIVA workshop is planned, and Dr. Joseph Montero is organizing in Hinduja. So we are definitely meeting. I guess we can send you an invite if you can manage to come. So it will be a great interaction in Mumbai also, because definitely few people are regularly practicing in neuroanesthesia, especially.
Yeah.
So
I-
definitely will be happy. Yes, Sona ma'am.
One small basic, we do not have TCI pump, Dr. Dheeraj. So
ma'am.
give us some advice on how to use it in neuroanesthesia with manual, infusion pumps.
So manual also sometimes I do, madam. So if BIS monitor is there, I can tell. Even without that, it is difficult. If you have a BIS monitor, then
Manual infusion. So
BIS monitor is there, no, madam?
Yeah, BIS monitor is there.
Yeah, if this monitor is there, after induction, you can start 1% or 2%, whatever you're using. So there is something called Bristol regimen. So 10, 8, 6 for first 10 minutes, you can use 10 mg per kg per hour. Then after that, 8 mg per kg per hour for the next 10 minutes, and 6 mg per kg per hour you can use for further part of your surgery. That will get you a TCI level of 3 micrograms per ml. So in that way, you can use manual infusion, but later on you titrate it. I'll tell you roughly, if you're using 1%, a male around 40 to 50 years would require anywhere between 65 to 80 ml per hour of propofol. And then you see the BIS and titrate according to that.
Okay.
Dr. Dheeraj, can I extend the answer for that?
Please, sir.
Madam, whoever I could know who was asking. The
And
other
ma-
alternative for you is if you have a BIS monitoring, you can download one of the apps known as Interactive TIVA, iTIVA. So iTIVA, what it does is it takes the same 4 parameters, which helps us give individualize the treatment. And you can, what you need to do is whatever the app types, you have to do exactly the same with the pump at that particular time. It says you start the infusion at 12 mL per hour, you start at 12. After that, it will give you a buzz, have to move on to the next level. So next level. So it will keep on there. Once you use it, you will find that lot of benefit is there. So you can try out the Interactive TIVA app as well.
Does it tell you when to stop or when to this?
Yes, ma'am. Yes, ma'am. If you want, let's say, for example, you have kept a target of 3, you want to reduce it to 2, it will tell you how long to stop. For example, you want to titrate up from 2 to 2.5, it will tell you how much to change, what you need to change, for how long. It will give a buzz as well. And the newer models also give an estimated BIS. I don't want people to confuse that. You should not use BIS. But if you are maintaining a particular concentration, because it's a PK-PD model, it also tells you what is the estimated BIS depending on the age, depending on the gender, depending on the weight, what is the estimated BIS also.
Thank you very much, sir. And in neuroanesthesia, Dr. Dheeraj,
Yeah, madam.
do this, meaning does it comply with the surgeons and the surgery, especially the leads, and does it properly reflect whatever the BIS and everything with the surgery, neurosurgery especially?
So brain surgery, if you're doing on the right side, you have to somehow put it on the left side, madam. There is a way to connect. I couldn't show here. So usually the active electrodes, which I explained, should come on the forehead and temple, and you can actually start placing it like this, in this way, if you're seeing my face. So
Yeah.
ground and reference can be here. Active electrodes will come here. So like that, if you place, 100% perfect BIS will come.
Okay. Thanks a lot. Excellent presentation, Dr.
Thank you.
Kalpana, Dr. Dheeraj, and sir for moderating. It was an excellent presentation. And as Yogita said, we have a TIVA, this thing also. There is a panel also on TIVA in our this thing, state conference in October.
Okay, madam.
Wonderful, madam. Thank you.
Thank you.
I really thank all the faculty, participants, and Society of Anesthesiology Maharashtra for providing this Zoom platform. And I really thank Dr. Kalpana and Dr. Dheeraj for sharing your expertise and insights, and wonderfully moderating the session by Dr. Mahankali. So I thank all the participants who enthusiastically joined and asked questions so that more clarity is there in future for using TCI and TIVA. So we look forward for more sessions like this probably in our state conference, the earliest event we can organize in Mumbai. So thank you so much, all of you, and goodbye for a day.
Thank you all. Have a wonderful day. Thank you. Bye.
Thank you.
Thank you.
So much for having us. Thank you.
Thank you, madam. Thank you all.
मॅडम मीटिंग एंड करू का?